Hello, welcome back. Today we will discuss a very important topic which is just published or not yet published. It's in the pipeline, but an early release article from the American Heart Association and AAP update on neonatal resuscitation. So some of you might have come across this already. Just a quick run through of what the changes are. But before we start, can I request all of you to subscribe if not already subscribed, and also please do like and share so that the video reaches more people and it encourages me to make more such videos. Thank you. So just a summary of the top 10 points from this update. The first few are related to cord clamping and cord milking, just clarifications on what to do at certain gestations, especially if the baby is in a good condition versus if the baby needs resuscitation. So for term and late preterm babies more than or equal to 34 weeks who don't need resuscitation, delayed cord clamping is beneficial compared with early cord clamping. So this is already incorporated in the guidelines, and this really has no change from what was recommended before. So delayed cord clamping is important for term and late preterm babies. And in the same group of babies, intact cord milking is not specifically known to be beneficial when you compare it with delayed cord clamping. So delayed cord clamping is preferable where it is possible to be done. However, if the baby is non-vigorous in term and late preterm 35 to 42 weeks, intact cord milking may be reasonable compared with early cord clamping. So if you are not going to do the delayed cord clamping because the current guidelines doesn't support delayed cord clamping in a baby who is non-vigorous, you can do cord milking. So we are still waiting for more details on resuscitation by the mother's introitus, for example, where we allow the lungs to open before we clamp the cord even in non-vigorous infants. So that is not part of the NRP yet. It's still in research. So in the meantime, in this group of babies, we can do intact cord milking. And the word intact cord milking is used to differentiate it from cord milking done after clamping the cord. So obviously that doesn't give you as much benefit as intact cord milking, where the cord is still attached to the placenta when you are milking the cord. So whatever you are milking comes back to fill and you will get more input. So studies have shown a clear benefit of cord milking in terms of hematologic parameters comparable to delayed cord clamping, but it is quicker and so it doesn't delay the resuscitation, so you can use in babies who need resuscitation. So this is a summary of the grade of evidence and the grade of recommendation as well as the level of evidence. So this is from randomized studies, grade B evidence, because it's only one or fewer randomized studies. And in terms of term and late preterm infants, this is for the first recommendation, the same for the second recommendation, only the 2A and 2B strength according to the strength of evidence available. In terms of cord milking known to be beneficial, that was more evidence for that. So for preterm newborn infants less than 34 weeks who do not require resuscitation, delayed cord clamping is beneficial compared with early cord clamping. Again, for premature babies as well, delayed cord clamping is a physiologic way. You can refer my earlier videos on delayed cord clamping and why that is a norm rather than the exception. And for preterm babies between 28 and 34 weeks who do not need resuscitation, in whom delayed cord clamping cannot be performed. So it may be, for example, multiple pregnancies where you don't want to do delayed cord clamping, or there is obstetric reasons like antepartum hemorrhage where you can't wait. You can quickly do milking of the cord as a baby is delivered. For the preterm babies less than 28 weeks, however, cord milking is not recommended. So this is based on Anup Kataria's study. This is a single trial investigating 182 infants born 23 to 27 weeks gestation who did not need resuscitation. Severe IVH was significantly higher in the babies who received cord milking compared to delayed cord clamping. So this is the grade of evidence. So the recommendation is level 3, no benefit, and this is from grade B evidence with randomized trial. And again, for preterm infants between 28 and 34 weeks who do not need resuscitation, intact cord milking may be reasonable. This is a 2B recommendation, and also from a randomized trial, a grade B evidence, level of evidence B. So here a single trial including 292 preterm infants of 28 to 32 weeks gestation showed no increased risk of severe IVH. However, there was evidence to show that cord milking does increase hematologic parameters, so you can use that in such babies. The remaining recommendations are about PPV and effective PPV. So it's very clear that effective PPV is a priority in newborn infants who need support after birth. So in babies, it's failure of the oxygen to get into the lungs as a first step. So obviously you start with effective lung inflation and oxygenation, and the next step you go on to the further stages in resuscitation. So again, you can refer to my detailed videos on NRP and especially the algorithm to understand this better. TP's resuscitator is preferred to self-inflating bags. So this again is very well established. In my NRP series, there is a separate video on TP's resuscitator, but this is coming as a categoric recommendation. So those of you who felt comfortable with the self-inflating bag and did not switch to the TPs, I think this should provide you the motivation to actually switch. This makes a bigger difference for the premature babies, especially as there is a reduced risk of BPD when you use. And obviously, you're giving a PEEP, which is very important for the premature babies, and you also have inspiratory PIP limits as well, which would help in avoiding the barotrauma in the premature baby. So it's obvious why this would help, but it's a stronger recommendation now. However, self-inflating bag should be available as a backup, even if you are using the TPs or flow inflating bags, as these need gas supply or flow. And as we know, sometimes your gas supply may fail for whatever reason. Also, the self-inflating bag may help you during transport if your gas supply isn't available. So self-inflating bag is not to be discarded. It's still to be retained as a valuable tool, and the training should continue in how to use it, because that's the one to use in emergencies when you don't have a gas supply. There is a recommendation about supraglottic airway, which is LMA, IGEL and similar, which may be considered as a primary interface to administer PPV instead of a phase mask for newborn infants delivered at or more than 34 weeks. Reason it's based on this gestation is that most of the available devices can be used mainly about 2 kilo birth weight. Some of them have recommended that it can be used above 1.5 kilos. We are still waiting for a size 0, which can be used in the smaller babies, and once it comes, this recommendation may be revised. So the main feature to look for is which baby needs significant resuscitation before you go for the supraglottic airway, because obviously it's more beneficial in terms of effect, but it's more expensive as well. So you don't want to use it for a baby with primary apnea who is going to recover quickly with a few PPVs. So I will again link my video on NRP, and there is a separate video on how to differentiate primary and secondary apnea. A baby with secondary apnea is more likely to be pale, is more likely to be floppy, and you can differentiate based on these. If a baby comes out with a low heart rate and is pale and floppy, you can go for the laryngeal mask airway. This is not the AHA recommendation. This is my own feedback on my own thought on this. So this is one way where if you have a limited supply, you can prioritize and use in these babies. Again, there are studies which have looked at the LMA as a bedside tool in the NICU as well for babies who need IPPV, because it recruits the lung quicker, the leak is less, and comparing different users, the inter-user differences are lower when you use LMA, because the seal is better. Once it goes in, it sits on top of the airway. So this is the recommendation related to PPV. TP's resuscitator is more beneficial compared to self-inflating bag, and this is based on a meta-analysis of 4 randomized controlled trials with 1,247 term and preterm babies. Resuscitation with the TP's resuscitator reduced the duration of PPV. It also reduced the risk of bronchopulmonary dysplasia, and though they didn't look at gestation separately, BPD is an outcome linked with premature babies, so you can safely say that this is a stronger recommendation for the premature babies. It didn't have any studies on flow inflating bags, because most flow inflating bags are used by anesthetists, so it's not surprising. Of course, we will mostly be using TP's devices, so we can stick with that. This is the reference if anyone is interested. The recommendation for the interface used to administer PPV, Again, this is related to the supraglottic airways. A meta-analysis of 6 RCTs with 1,823 infants delivered at or more than 34 weeks showed that use of supraglottic airway reduced the probability of failure to improve. It's a challenging one how they compared, because each baby is different in terms of response, and so the studies have to be looked at. I haven't reviewed the articles myself, but obviously overall improvement, it's logical that supraglottic airway would provide a better seal, more consistent delivery, less likely to be dislodged when you are distracted in the resuscitation scenario. So you could also show a rate of endotracheal intubation to be lower in this group. So there are two benefits: quicker improvement and lower need for ET tube. So failure to improve was a pragmatic outcome which was chosen to assess the benefit. So the duration of PPV and the time until the heart rate reached more than 100 were also shorter with the supraglottic airway. So if you are trained in use of the supraglottic airway, most of us have it in our crash carts, but we are not using it routinely. Also, the stock may be low because you have not used it. So once you decide that you want to use it this way, it's better that you look at getting more of these, and cost effectiveness has to be a factor. So you can look at how best to optimize its use. So this is it about the update, and do share your thoughts and feedback as well in the comments. Thank you.